We are working with DHS on data that where we think people would fall in the categories, but so far the savings that we have, there's not a predetermined number of people that would fall into the different categories. Our statement to DHS all along and all of our communication about the assessment has been that we advocate for an evidence-based clinical instrument to be used and that the people are placed in there and that the assessment would be a comprehensive determination of all Medicaid provided services that they receive. So there's not really a savings dollar amount tied to that. We're not expecting a certain amount there.
Well, then just a short follow-up, Mr. Chair. If you're not projecting a savings and you have no estimate, then there could be a cost increase.
We don't expect there to be an increase because right now in a lot of these services, people are automatically receiving the maximum amount, and so we don't know where they will fall, but there won't be a way for them to go over that.
Okay, thank you, Mr. Chair.
Okay. Right, and there will be modeling set up to address it. But the overall goal with this is that we've discussed is try to delay entry into a nursing facility on the long-term care side for 6 months. When you extrapolate that over the whole state, that gets into big numbers. And so we're trying to do right now it is very, very cost effective for the state of Arkansas to have someone in a skilled nursing facility. So obviously, we've been involved in national discussions over the last week or so, especially discussing block grants and per capita caps and different things that seem very, very likely. And so we want to work in partnership with DHS and the governor and our legislative friends to develop a process where instead of having some Armageddon nuclear issue whenever caps or block grants or any scenarios possibly could happen, that we should have a seamless transition into whatever transpires that's good for the citizens of Arkansas and can make sure that we're providing high quality care in a fiscally responsible manner.
So some activity to date on our MOU and just looking at nursing facilities. One thing, you've heard about the changes to the provisional rate. This is a component, a part of the nursing home reimbursement system. And the provisional rate is something where if you have a facility that is poorly operating, under distress, there's survey problems, and a new operator comes in and purchases that facility, the new operator historically has received a temporary enhanced rate that would allow them to come in and increase staffing, make physical modifications and improvements, and the provisional rate has been something, it's worked really well, and to its credit, we have a lot of new updated facilities to be proud of in our state, but it's something, an area that we saw we could see some savings pretty quickly without a negative impact to patient care. And that has completed public comment with DHS, and it's already gone to public health, and so we're pending the final pieces of legislative review, but that will be a total of $7 million of savings per year, go into effect January 1st. The next piece on the nursing facility changes in the MOU, we've placed a cap on liability insurance premiums. Nursing homes, many of them have liability insurance. Many of them, because of our liability climate, don't have any kind of insurance, and reimbursement for that is available to a degree in our reimbursement system. And so there's been a cap that's placed on premiums that it's all filed in our cost reports, and that has been done, also completed, gone through public health, and will be a total of $2.3 million of savings per year. The last piece here that we've done.
Can we get a question here real quick? Representative Hammer, you're recognized.
Thank you. Rachel, can you remind me on that one, on the public comment period, what kind of feedback you got on that, and what was the reaction to that proposal?
On insurance and provisional?
The cap on liability insurance premium.
We didn't really receive, but there weren't comments on that.
Weren't any at all?
No, we've received a lot of support on that, both from legislators, operators, different people. We have some operators that, they're not really excited about any kind of cuts or savings, but they understand that it's necessary. We've not received negativity about that.
All right, thank you. Thank you, Mr. Chair.
So are you just, can you explain to me what you actually mean by that when you're capping the liability insurance premium?
Okay, so So basically what it is put a ceiling on, they all have to be actuarially based or whatever, so someone who's had problems with their facilities and their actuarial numbers were high, and so their insurance premiums were high for their Medicaid patients. I mean, we put a cap on it where those fees, even though they pay them, are not, for Medicaid patients, are not reimbursable. So
So the operators would eat that cost.
the operators will eat that cost.
So basically it goes to what they're going to get reimbursed through Medicaid for their liability premiums. It may not cover the entire cost of the premium. And does this require Fed sign off or no?
No. And hopefully in the future, we would love for this to, for substantive tort reform to pass, and we could much, much, much lower this amount even more for further savings.
Okay.
And then finally, here, there have been some changes made to the population-based bed methodology. New nursing home beds come into our system historically in two ways. One, by population-based changes, which is where in a county, the number of people over a certain age number, and then also utilization based on the number that are being utilized in that area. And so we've made some changes to the number of population-based beds. This is not a moratorium. We've got a lot of questions about that. However, what it will do, it will slow the growth of new nursing homes coming into the system. Our statewide occupancy right now is around 73%, and you saw that graph that I showed earlier where the number of patient days continues to decline. We feel that right now we have close to the number of nursing homes in our state that we need, and we want to slow the growth of that development a little bit as we adjust to some of these reforms. And that one is through, not through DHS, but through the Health Services Permit Agency, and it's out for a 30-day public comment period as well, and that should go through the legislative process later this year. And then on the home and community-based service side, some reform that's happened there. Our assisted living waiver, as you're aware, was just renewed, and it was renewed for 5 years. The previous waiver had an automatic annual rate increase for 5 years, and we had a number of slots of 1,000 slots. 1,000 people could be receiving those services at any given time. That waiver was renewed for 5 years, but the 5% annual increase was removed, and the slots were increased to 1,200. And the rates were basically frozen from the 5th year of the original waiver going forward, and CMS had requested in advance of this for the state of Arkansas to do a rate methodology study because they didn't have evidence of how those rates were set last time. So we'll be working with the department. We've looked at some surrounding states, their assisted living regulations, how those rates are set, and that could be changed before the time is complete, but right now that's been renewed, will stay flat. The next piece is the AR Choices waiver. This was formerly Elder Choices, and it was renewed back at the beginning of this year. And these are people that are medically nursing home eligible, but are still able to, they're not at a skilled level of care, they're still able to live in the community, maybe with a family member or some kind of support. They receive services and support in the home. And there was already an assessment in place for this waiver, but that part was strengthened a little bit and some of the details were added. Independent assessment on this one, which allocates hours and services based on the need of that client.
Okay, we got another question. Representative Hammer, you're recognized.
Just for us laymen or for myself, would you explain to me how it is that item number 2 actually translates into savings without, I mean, these are all proposed things that are supposed to generate savings toward the bottom line, right? So in a nutshell, would you go back on number 2 and tell me how does that actually translate into savings without
Number
too
2 on
deep
the
in the
list,
weeds?
or the one I talked about second?
Okay.
You mean the assisted living or the other one?
Assisted living waiver renewal.
So assisted living waiver renewal, we don't know that it's savings right now, but it's definitely not an automatic 5% growth. It kind of pauses that waiver where it is to where they can look at the rates and reset that.
All right, so some of these aren't going to necessarily turn into dollars immediately as much as it is. It's going to slow and address the process and give you a chance to review it
Right.
over time. Okay.
And
all right.
what I'd like to add on the nursing home side before, those numbers on savings with the nursing home changes, with the insurance, the provisional rates, some of those other things, those numbers are what we can absolutely verify with our accountants based on the cost reports. But the bigger savings will be over time with behavior changes as this whole system kind of works together better than it has in the past. The behavior changes will be a big driver there.
And that's a lot of what, that is what some of these are intended to do, because we can kind of like throw money at it for now, but if we don't change the patterns and
Right.
the direction we've been going, then we're going to be right back where we are 5-6 years from now.
Correct.
Okay, all right, thank you. Thank you, Mr. Chair.
And then finally here, independent assessments. I know you've heard a lot about this. DHS has released an RFP for a contractor to perform independent assessments. Right now, this is being done on the home and community-based side, on the AR Choices waiver and the assisted living waiver. I know there's a lot of other activity on assessments with DD and behavioral health, but we have our position on this is that it's a the evidence-based instrument that's used to determine eligibility, and the NRRAI that's used right now on home care translates over to the federally mandated MDS that we complete in all of our nursing homes. And it's our goal, as Representative Hamer pointed out, that will not just kind of pick and choose in all of these programs. When you think about all the services available to the elderly and all these different programs and services that we see, that part of this is thinking about how to put all those together and make it to where there's better coordination between the nursing homes and the community, and that when that it's more friendly for a consumer to navigate that process.
Okay, Representative Hammer, you're recognized. I'll push your button again. Okay.
Thank you. On that independent assessment tool, there's been some controversy in the last several months, maybe in some other committees, possibly in this one, I don't remember, about the tool that's going to be used, about the credibility of the tool that's being used in these assessments. So you mentioned RAI, I think you called it, is the one. So what is y'all's position as far as that tool being the best that's on the market to use, and how well will it be able to be integrated into other systems such as the RFP for, that where we have a seamless ability to share information across all the agencies and everything. So I'd like to hear your professional opinion about that assessment tool you just mentioned, and is there another one we need to be looking at using?
I think there are a lot of tools on that. I can just speak to the aging side. I don't know the DD and behavioral, and I think some of this is going to overlap later on. But on aging, the NRRAI is a good, competent, qualified tool. It's evidence-based. It's been tested in many states, many countries, and as I said, there is overlap to what we're federally required to use in the nursing homes. There are a lot of other ones. More so than just thinking about the tool, I think it's important for policymakers to think about what is our software platform, how will it integrate with other pieces, and not just what the tool is, but what is it assessing. So in the past, DHS has had an assessment tool, but it might only assess 2 or 3 of the program. If you have an elderly person and they're receiving an assessment, it might only assess 2 or 3 of the programs they're receiving, but they might be getting services from 5 different programs. So our position has been that this assessment should capture all of the services that they're receiving, because oftentimes there's overlap, or there might be something that they don't need, or it could be a service we're paying for that they're not receiving, some kind of issue, but that it should be a complete, comprehensive snapshot of everything that person is receiving, and to show a history of it. So how the software system and that platform is designed is really important, and looking at the comprehensive needs and services that they're getting, I think, is almost more important than the tool itself. There are a lot of qualified tools out there.
All right, so is it AHCA's official position that tool you're comfortable with as far as meeting all the components that need to be looked at, and the tools on the market, that one's okay with you guys?
Yes.
Yeah, the backbone, we believe we can implement it with this tool, this is the evidence-based competent tool. It has some drawbacks. Every one of them has some drawbacks. But this tool, we believe, will bring and deliver the best value for the money to the state of Arkansas and adequately deal with what we need to do.
All right, thank you. Thank you, Mr. Chair.
Okay, the next slide has an image here with the new model for LTSS care delivery. And as I mentioned earlier, we want to encourage everyone, this is not just thinking about the nursing homes versus the community services. This is about placing people in the right location, but more so about all of those different service providers working together. So different components here, you see comprehensive independent assessment of needs, the level of care and services budget determined, that would be based on the assessment. And then the third piece is the care plan that authorizes home and community-based services or in-home state plan services. And then finally, those clients would receive care management, coordination, and care transitions, potentially looking at a health home or a way to do that. So I talked about people that reside in a nursing home oftentimes transition in and out of a facility when they're elderly following a rehab stay, or maybe they go in for a short time, they're able to go home. We want part of this to improve the transition of those people as they go through the continuum. This slide talks about tier levels of care, and this is something that we're working to develop right now. So the tier levels of care, there are 3 here: the highest needs, high need, and moderate need. And these are going to be people that qualify medically to go into a nursing home. A lot of times when someone qualifies to go into a nursing home, they're still able to receive services in the community if they had some extra support. So we're looking at what things could be put in place that might keep them in their home while being cost efficient, keep them at home longer, whether it be medication reconciliation, having a therapist follow them home to assess their physical environment, looking at some of those things that other states have put in place. You might have heard people call it a preventative tier or preventative level of care. The state of Tennessee and the state of Rhode Island have both put that in place, and we're going over all of their data right now to see how that's turned out and what the cost has done in those. Making sure that this is not just adding a new service category, but really matching their services to need. So in summary here, we have several policy reform items, both on the nursing home side and the home and community-based side, are underway through rural and state plan changes. We've tried to, some of the things that we've known that we wanted to do and planned on, we've already started those through the process, and we're working on what would need to be done during the legislative session. And the next steps that we're talking to DHS about right now are personal care reform options for DHS consideration, because there are a lot of changes there, and then the LTSS care delivery reform model that we're working on, the whole concept with the integrated assessment model and potentially health home. And we'll work on a process to keep legislators updated as we move forward with this. And for example, on the personal care side, that, as you know, that's a state plan that affects people that receive DD, behavioral, other services. It's not just the elderly, but I know DHS is working hard on reforms and changes across the board, and so we'll be working with them to make sure that this can all fit together. And then this timeline is what was presented by Governor Hutchinson in our MOU ceremony. This is a big picture overview of timing, and for the most part, this is on track now that this population-based beds is going through the legislative process as well. But we're continuing to gather data and research and look at other states, and so this is the big picture timeline here. And then as an attachment, you should have received a detailed timeline, and I'm not going to read through that, but I'm happy to answer any questions about that. But that has a little bit more detail I thought you might want to see in addition to this public timeline here.
Okay, let me just ask, on this agreement, it was signed in May, $250 million over 5 years. I guess what I'd like to know is, do we see that front-loaded, back-loaded, or split over $50 million a year for 5 years? What is the expected timeline of the savings?
It won't be exactly $50 million every year because of the timing of all of this. I think probably you'll see the most savings in probably years 3, 4, and some on 5, but that's what it's going to take, that much time to where we can get the tier levels in place, get the assessment instrument in place, and the changes to the personal care state plan. We're finding the assisted living waiver reimbursement amounts, but it'll be heavier years 3 through 5.
You have any estimate, and when you say, are we talking state fiscal years, July to, so do we expect any savings in the fiscal year starting July 1st of 17?
Based on these changes that I talked about on the nursing, on the provisional rates, the liability, all of that's effective January the 1st of this coming January, so you'll start seeing some of those savings there.
So some will be in this fiscal year that we're in now. And is there any reconciliation at the, as we move through this, if we're on target for this 250 million process, is there any way to say, you know, we're halfway through and we are not utilizing the savings or that we thought, or that they're above that? How's that process work?
Yes, so our consulting firm, Sellers Dorsey, has been working on some different ways to model that, and our accountants have a lot of historical data, nursing home cost reports and information from the state, and they'll be working with DHS to do that. They've had some delays in getting some data because of some turnover there, but we will have a kind of our hope is that we'll have, starting next calendar year, that we'll have a quarterly progress report that would be sent to the legislature with kind of where we are, what we've achieved, and what's remaining.
Yeah, and I think that's an important point for members to recognize is, moving forward, where's going to be the collection point for this, and so that as we change legislatures and change members, that we have some corporate knowledge of what we're doing here. Representative Hammer, you're recognized.
Thank you, and I appreciate the presentation, a good faith effort. Let me ask you a couple of the hard questions, and that is, what is the stick that we can point to in the proposal that says that this is actually going to deliver, and in the event it doesn't deliver, then what becomes the liability that has to be assumed by y'all, the providers, and are there any liquidated damages that are included in the proposal? Because projecting is one thing. As we progress and go along, if the deliverables are not met, what's the responsibility y'all hold in the event that happens?
So one of the things that, on the timing and different things, what I believe you'll see is more front-loaded savings on the nursing facilities, because that's somewhat more in an easier, less complicated reform proposal. And so you'll see things like value-based purchasing, payment withholds from the nursing facilities, with a quality-based where they can earn part of the withhold back. And those withholds will be driven on value-based. So you'll see that will actually both do savings and significantly drive behavior the way we've looked at designing it. So you will see decisive savings based on that program on the nursing facility side. The CMS requirements, and that is somewhat more within our control here in the state of Arkansas. I mean, we still have to do some state plan amendments changes. Obviously, I think our reform efforts, much more excited about them with, and it's just different with the change of the administration that we're going to have to deal with. We don't know who we're dealing with on some of the other reforms that's going to be very heavily involved by CMS. So those reforms are going to see more on the backside. But specifically talking about the skilled nursing facility reforms, you're going to see specific payment withholds, and it's going to be concrete.
We expect that to start in July.
So,
Okay. So that, now, we're going in with a memorandum of understanding, but how does that transition into something actually contractual? And I guess I'm asking for educational purposes, or are we going to be operating under the MOU from here on out? And, or help me through the process of how we know that this turns into something tangible and contractual from a MOU. And Chair, feel free to educate me, because I'm wondering how we're.
Well, again, I think that goes to the point that I just made, is there's going to have to be review of this as it progresses through the 5-year period. And I think that's built into the MOU. I think what there's some uncertainty about is where's it going to be reviewed, and I think that's something that we'll be discussing in the next coming meetings amongst ourselves, is what is going to be the entity this review? Is it council? Is it health? Is it a new committee? What? So, but yeah.
And it's kind of, sometimes, some of that is a little bit hard to quantify because it's not, it is so big and comprehensive. It's not like we can say, here's one piece of legislation or here's one rule change to do this. It's going to take a whole variety of things to change, you know, turn the whole ship around and make some changes there. And looking at predicting the future and thinking about population changes for this sector. So it's a complicated process, but I do understand your question. I think there will be needed legislation during the session, and we're trying to define that right now and work with DHS on what that will be. And as David said, I think the payment withhold, as we discussed before, is kind of a safety net, so to speak. That value-based payment here would be a withhold in good faith from the nursing home operators in case something didn't work out.
And that would be the worst thing, I think, that could happen both for your industry and for our position as
Right.
legislators, is to get 6 months, 8 months down the road, and what we're talking about today doesn't translate into reality with no responsibility or accountability for, we'll just get fired, but
Right.
what will y'all, you know, what will be the skin in the game that y'all bring in order to make sure it's contractually sound? One other question, going back to the universal tool that I was asking about a while ago, that universal tool, is it adaptable regardless of whichever applications it's applied to? For example, Curum or any other vendor out there that may be competing through the RFP that was mentioned earlier in the meeting. That tool is adaptable to any one of those systems. Is that correct, or do you know?
That's my understanding, yes. It's more about how DHS designs and sets those expectations on the front end for, you know, whoever that vendor ends up to be.
Okay, thank you. Thank you, Mr. Chair.
Okay, that's all we have on the list. Thank you all for this update, and I appreciate your proactive attitude as we move through this. Thank you. Okay, members, I think that Mr. Condalucci his plane just landed. We're going to go ahead and go to the next item, if that's all right, and we'll skip him to the end of the agenda. So, John, if you'll bring your folks down, we'll get updates, which is Exhibit F in your packet. Thank you all again. Well, welcome back. I think you guys know the drill. Just state your name for the record, and you are recognized.
John Stephen, Managing Partner of the Stephen Group.
Stephen Palmer, Senior Consultant at Stephen Group.
Rory Rickert, Senior Consultant, Stephen Group.
Richard Kellogg, Senior Consultant with the Stephen Group.
Thank you, Mr. Chair. And first, I want to say happy Thanksgiving to all the members here. We're going to go through real quickly this agenda, and I want to make sure we have enough time to cover savings and remaining recommendations as the last two items. So the first four items there are just really items that Representative Collins had asked us to follow back up at this meeting. We were ready to discuss last meeting, but we didn't have enough time. So we're going to go through those real quickly. And I'm just going to run through, and the reason why these are here for you all to take with you, we are going back over and reiterating some of the things we've told you a while back about the, I want to call it cost shift from the traditional Medicaid into the private option, i.e. Arkansas Works. And if you just go through slide 3, and we talk about some of the areas, you will see very much same in slide 4, some of the populations. So this is not unfamiliar. And then this is the spreadsheet that I know Representative Collins used often and refers to. It has been updated January, this is the January 16 forecast. DHS was looking to update this and is currently reviewing it, and you'll get the benefit of that in the next session. But the key here is going to be to look at the slide in page 6. I think what we're trying to show you here is, as you look at eligibility, and you look at where the increases have been in their eligibility under the Arkansas Works private option, you could see the increases in newly eligible, but also the Social Security aged, some of the medically needy, and others have dropped off of traditional Medicaid and went into presumably under the newly eligible. And so this just gives you a snapshot of kind of a graph. And then if you look at the next slide, 6.
Before you move off of that
Yep.
one, it seems to me like if that's the case, then on page 6 there, in May of 16, you show a big dip in everybody, that there would be an increase in some, like in the expansion population, and a decrease in the others. Why do we see a decrease in everybody
Stephen?
in May of 16?
And so the way that this chart is put together, you can see that the vertical span of any given color is sort of the number in that category. That dip that you see is actually driven by that dip in the low-income children and pregnant women, and all the others largely keep the same size. They just drop vertically within the figure. I'm not sure what actually drove that dip in the number of enrolled pregnant women and kids in May of 16. As you can see, it sort of picks back up in September. There may have been some adjustments having to do with the eligibility and enrollment system at that time.
Like I say, I don't get it, because there's a dip in every category.
Well, they all go physically down, but the only one that changes its height is that pregnant women and kids.
Oh, no, that's not a very good way to represent the data. So you're saying that even though the yellow band is the same, it's the same value, but,
Correct. Yeah, there are different ways to represent this.
okay, gotcha.
The next slide, though, gives you an idea of the actual numbers. And what Stephen has put together here is to give you an idea of before the private option and during the private option, and then you can see the percentage change. And I think what the reason why this slide is telling is you can see where there's been some substantial drop in some of the population and some of the really high-cost population, significant drops. Although they're small numbers, they're high cost towards the end. And presumably, a lot of them have been shifted into the private option, which, again, the message that we want to deliver here is to just, whatever happens in Washington in the next few months or years, whatever happens in terms of reform, that you pay attention to the fact that there's been significant dollars of Medicaid eligible costs that have been put into private option at an enhanced rate. And when that all changes and the environment changes, just continue to pay particular attention to those match rates. They become very important. Okay?
So like how big a hole in the budget would it be had that not happened?
Well, I mean, potentially $100 million a year is what we were looking at originally, just rough numbers.
That's what we save by transferring medically eligible people to the expansion with a higher match rate.
Generally, yes, and it could go up.
Right.
Rory is here to talk about the pharmacy savings. Real brief, you're going to see them later in the savings matrix, but basically on track, and Rory's been working with Department of Human Services.
And the only recent update is in the final row of savings, their retail pharmacy reimbursement reconfiguration. CMS asked the department for some additional clarifications in their request for approval, even though this same reimbursement methodology has been approved in other states, so there's no reason to expect it won't be approved here. It may trickle into the early part of 17 for implementation, but everything else on the slides is as is.
So you're saying that beginning the fourth quarter of this year and moving forward, the total savings are 52 million? Is that on an annual basis, or?
Annual, and we projected these through calendar year 17 through 21, those 5 years.
So that's a 5-year savings or a?
Annual savings, but flat over, it'll be 52.5 million a year for 5 years.
Okay. Is anyone from DHS, they all agree with these numbers, that what they've done is going to decrease their expenses by $52 million a year?
Yes, I've worked really closely with them on
You shake,
developing
yes or no? Yeah, okay.
And I think you'll see when we go through our savings matrix, we've put it down for like 50 million for 5 years straight out. I'll share that with you.
Okay.
Representative Gray had mentioned at one of the meetings, a couple meetings back, about a jail diversion program in San Antonio, and I believe she's had the ability to go and visit and view, and some of our team working in Texas, we know some of the San Antonio folks that have this program. Richard has done some additional research for you, and just real briefly, we'll give you an overview here, and then if you have any questions, it's a really good program.
Thanks, John. Very briefly, in the last month's status report, there's an extensive report on jail diversion in San Antonio and the surrounding counties, as well as some other state models to look at. Basically, it's a community partnership. I think that's the big message. All the elements of your public sector that you would expect to be involved, from mental health to the police to the counties to your hospitals, are involved. The components are listed here. I think some of the key constructions here is it takes time to develop. Scale is really important in size of what you can accomplish. San Antonio, Behar County is really large, so the savings generated are really large there. The focal point in most models is a center, a mental health center, where law enforcement can bring people that they arrest on the street. That's what it really comes down to. Some states have a law that allows for what's called a 23-hour mental health hold prior to a decision made for either the person being civilly committed to a psychiatric hospital, re-arrested, re-picked up for arrest, or released to the streets. Those are really the three key variables. Another key variable in these models is whether or not the diversion takes place pre-booking or post-booking. Has a major...
Richard, I'm sorry, could I just interrupt you for a minute? I've just been informed that the Criminal Justice Reform Task Force is also working on some of these same things.
Absolutely.
Okay, so as long as I just want to make sure that the right hand knows what the left hand is doing. Fine to go ahead and cover it, but let's just make sure that the right hand knows what the left hand is doing after the fact if we haven't done it beforehand, so that if we're sharing it in two places, fine. I just want to make sure that we each know who's going to pull which wagon, that's all.
I think that's a great point. Representative, we're only advising the task force on this. We haven't done any other work outside of the scope of work. In talking with Ms. Gray, who just was there, we have really focused on the fact that apparently you do have all of these elements in state government and local government talking together, so you have a very good opportunity, I think, to take this to the next step in terms of your planning.
And again, this is just based on Representative Gray's questions to us, as follow-up from that question. So to have it as part of another committee's discussion, we can send them some material from what we've learned ourselves as well.
Okay, Representative Gray, did you have a question? Okay.
So then we move into the savings model. And so this part of the agenda, the next two parts of the savings matrix model we've put together for you, which will be in the final report. So it's important that, you know, we go through this with you one more time here. We've spent a number of meetings over the summer going through each of the areas. You heard from the long-term care, the $250 million. You're going to start seeing some numbers that we're putting in. I underscore, these are estimates. We've tried to do the best we can with estimates. We've also worked with DHS over the past few months to make sure we look at, even in the behavioral health area, for example, we drilled down to the code level. We try and understand their plans, trying to figure out exactly what they're going to do, and then we look at other states to see what other states have saved in terms of some of these models. So this is really important because the task force, this is really, in my opinion, on your traditional Medicaid reforms, you have driven these reforms, and DHS has acted swiftly. And I am very, or I know my team is, we're very happy to tell you that, you know, in some of these areas, DHS has really responded well and they've gone forward on rules. They can update you on timeline. This would, in my opinion, this would not have happened without the impetus behind this committee. So we'll go through it. It's very important. It's going to be in your final report. And this is a dashboard or a matrix you'll be able to use going forward. So in the development disability area, you can see there are going to be saving strategies built on therapy caps, independent assessment, and tiers into the waiver services. We'll talk about that again when we look at the numbers. I'm just giving you a brief overview. What we have not included in the DD area is DDTCS and also CMHS, which is apparently going to happen through a screening tool, and we're still working with them. So we're going to talk about that in a moment. There'll be savings, additional savings will probably be written in there. But this is, therapy caps have begun in terms of rulemaking, and we assign certain savings to that, and Richard can answer some of those questions. They're going to have an independent assessment. Then the behavioral health, we're looking at complete RSPMI overhaul in terms of the benefit structure. To their credit, they've really moved forward in designing a real good package. And we're going to see substantial savings over the next few years off of trend in the behavioral health area. Some of that's still going through the system, but scheduled to begin July 1st, 2017. What's important for you all to recognize is fiscal year 18 starts July 17. So when we go through the savings numbers, fiscal 18 is when a lot of the savings we've tracked will begin. But we want to give them credit for some things that are happening right now. And we were giving you numbers early in our October report of 15, but that was assuming things would start right away, January 16 or 17. There's been a lot of time and some delays, but to their credit, they're back on track. But you probably have given up a year where you could have had some things being done. But we're tracking from fiscal 18 pretty much. When we say 5 years, fiscal 18 to 2022, I believe. The dental, you heard from them on the dental program. Again, great movement, getting that RFP out, and hopefully through the evaluation process, they'll pick the right vendor or vendors, and we'll start seeing savings. You heard from the elder area. Low cost, no programs, that's your PCMH program. We've showed you early on, there are no additional savings off of trend, but there are savings. So I want you to know that there's still savings in that program, but they're just not off of trend. If you want to get additional savings in PCMH, I know Stephen has mentioned in the past some additional high-cost populations going into that area, and that's something DHS is going to be reviewing. Rory had mentioned the pharmacy savings, the $250 million in savings, and those have already begun. So you're going to have a little more upfront on those savings. So when you start to look at this current model, this chart is really important because you're going to start to see, just again, estimates on savings based in each area. And some of these numbers may not be entirely agreed to by the department in terms of timeline. They may think they're going to get some savings early on, quicker. We were trying to be conservative. We may not have been as aggressive as you'd like, but we're trying to be realistic and reasonable.
Can I just ask a couple questions about some of these? So,
Yep.
In the second group there, we're under net DD savings, behavioral health benefits policy, the 15 million, the 16 and 33, is that the group therapy rule that we just did?
The first 15 million is the group therapy rule change.
Okay.
And that will end in July of 17, because then you're going to go into a whole new redesigned benefit structure.
And is that, where is that?
That's going to be in the 16 million. The whole benefit structure starts in that first year. And then really $33 million a year in that, and including the 25 as well, in outpatient and inpatient.
And this redesigned benefit structure that's supposed to go into place, who's building that?
BHS has built a completely new portion of the Medicaid policy, and I think they've already proceeded through public health, and they'll be coming up to the next part of the process. Their timeline was to have this approved by December, and so far they're on track.
Okay. And then the other savings that you have up in the top, DD Savings Therapy Caps, is that the one that is proceeding through the legislative review process now?
Yes, sir, I believe it is. And that is a state plan service for occupational, physical, and speech therapy. And those benefits are eligible for all Medicaid-eligible people, not just the people who are eligible for DDTCS and CHMS services.
Okay, and then and you show that one actually taking effect in fiscal year 18. Why is it so long off?
Well, it's going to start July 17, 2017.
Okay.
And keep in mind, I mean, the department the numbers may come, it might be $25 million in savings at the end of that first year. This is why it's got to be tracked and monitored, or it could be less. This all is dependent on the prior authorization process and making sure that it's done the right way. And we tried to be conservative to identify, we didn't have real high savings the way some of these numbers we were looking at first, but I think about 25% approval rate on prior auth is what we used. And I think we looked at other states for their approval rates as well.
And then the very bottom item there, pharmacy, that's the one that you just covered, the 50 million savings that's already in effect.
Correct.
And you just should hold it flat across the,
Correct.
yeah.
And then the elder, you'll see a 15 there on the elder savings. Director Cloud and I have had some discussions. We looked at some trends that are coming down on the nursing home admissions, and we feel that at the end of this year, by July 1st, 17, there'll be savings off of trend generated in the nursing home area. So we want to include those.
Yeah, okay. Representative Gray, you're recognized.
Thank you, Mr. Chair. Question, as I look at the DD savings, so the independent assessment and tiers waiver changes, do you know where are we in the independent assessment process and/or the tiers? Do you?
It's a good question. The independent assessment process, the RFP's been issued, and the department would have to answer the tier issue. What we're looking at is, I talked to Melissa yesterday, and we may not be in 100% agreement on the timeline here, but pretty much the numbers we are in terms of the tiers. So questions relating to what those tiers are going to look like, when they're going to be in effect, what the waiver has, those are questions the department would have to answer. But we are assuming here, Representative Gray, that by fiscal 20, that state fiscal year, everybody would have gone through that assessment, the tiers would be in place, they would be similar to possibly state of Tennessee. State of Virginia just came together with a 6-level tier process approved by CMS, most recent of any state. I think they said in the past they're going to follow Tennessee, but there's still a lot of questions out there, and that's going to obviously go beyond December. And I know I think I saw the director here, not sure, but I think, and one other thing I would say here is the screening for the DDTCS and also the CHMS. Richard is working with Melissa now, and those are going to be additional savings we'll have in the final draft that you'll see in the final report. Just not comfortable yet on exactly what those numbers should look like. So that 135 is going to go up, but again,
Okay.
I'm not comfortable today to report that to you.
Okay, thank you. Mr. Chair, if we could at some point, could we ask Director Stone to come up and just kind of help us through the process? If they're going to report this to us in our final report, I just want to make sure that we are on track with this one last piece. Would that be acceptable? Thank you.
Yeah, let's let these finish, then we'll ask.
Thank you.
Okay, so that's...
Before we press on,
Go ahead.
Representative Sullivan's got a question. You're recognized.
Thank you, Mr. Chair. You mentioned a 25% approval rate a minute ago. I don't
It
understand
would
what
be,
that was.
I think it's 25, yeah. So what we looked at is a number, it may be 25, it may be a little less, Representative, but what we looked at is other states, when they had caps, similar caps, went through the prior authorization process. We're assuming that there's going to be a certain number of individuals that will get through that process.
Okay, okay.
That's what we're referring to.
Okay, yeah, thank you. Thank you, Mr. Chair.
And so what we didn't do is put the savings being off of that large amount that everybody's going to get denied. No, that's not going to happen. DHS is going to, and Beacon is actually the provider. And Beacon is going to be very responsible from what we've seen And we believe there's going to be a significant number of folks that are going to get through that, but the reasonable ones, it's not going to be a large amount.
Okay, we got one more. Senator Chesterfield, you recognize?
Thank you, Mr. Chair. When was Beacon decided as the independent assessor? Is that what?
No, Senator,
Beacon?
this is just the prior authorization process that they do today. They're the contractor
But
today.
they're the ones who will be deciding whether or not, for instance, if my doctor says I need this, they've got to go through Beacon in order to approve it. And if they choose not to approve it, then to hell with what my doctor said. Is that what where we are?
Today, they're going through that process today for, not the caps, this is a new area. So the department may end up doing another contract, or they may do a whole nother RFP. I don't know what their prior authorization contractual process is going to be. But yes, today.
So approximately 75% of the folks looking at what you're saying will not have their appeals approved.
It would be a
If you
denial.
look at, there will be a denial of about 75% of the appeals of the decision made by Beacon. Now, what?
Again, that's just
I
looking
mean, I
at
understand
some
it's
other
just a
states.
ballpark.
It could be different here.
Predicated on other states and the knowledge that we have. What uniquely qualifies Beacon to be the group that says no?
Richard?
That's an excellent question. I think, let's be specific. We're talking about occupational therapy, speech therapy, and physical therapy. The technical answer, it depends on what credentials the state's going to require whoever does this prior authorization and however they contract it out. I've met with the folks that provide these services, and in professional context, they would recommend that the people that actually review these services have the credentials of the people who actually deliver the services. And we would consider that to be a best practice. In other words, it would have to be people certified in speech therapy, occupational therapy, and physical therapy by the state of Arkansas, so that people who are, in fact, professionally qualified to deliver these services would also be professionally qualified to assess the appropriateness of use.
With your familiarity with Beacon, would you say that they're uniquely qualified to do that?
I can't speak specifically to these specific services because they currently aren't doing it, but I do think that they've done an excellent job for you in the behavioral health area, given the construction of the contracts, given the requirements of the contracts, and given your Medicaid Fairness Act.
Okay, so were they known by another name before this?
I think they've always been Beacon in this state. I don't.
They were not,
were they
that's not value options.
Yeah, there were value options, and then there was some integration.
Okay.
But I think
So-
it's the same, I think it's generally the same people that have been here in Arkansas dedicated to this
So
program
this is
over
the
many
value
years.
options group, AKA Beacon.
Beacon, yes, I guess you could put it that way, Senator.
All right, thank you, Mr. Chair.
Representative Hammer, you recognize?
Thank you, Mr. Chair. When dealing with somebody like Beacon or Value Options, are there some federal requirements that come down as far as who we as a state can have in that position in order to be able to make sure that the patients and the clients are being assessed by professionals with federal input as to who those people are?
Yeah,
Or those-
CMS will have to approve whatever the state's going to do for pre-authorization, reauthorization, utilization management, denials. Yes, they would have to do that. What specific credentials CMS may require a state for specific professional credentials, they usually defer to the state's credentialing process.
Okay, all right, thank you.
And again, the Medical Fairness Act requires hearing also after any type of decision. So there's still that process in place. So basically, moving on, so these are the models we've used, the numbers. You're going to see down at the bottom, the net fiscal impact is $893. I remember Representative Gray had asked at one point, I think it was the last meeting, so, you know, the managed care savings versus managed fee-for-service, this is all programmatic savings. So the important thing to notice here is these savings are being generated by DHS action administratively at the program level. When you bring in a provider level care coordination, care management, the type of organized care that Dennis Smith mentioned at the last meeting. You're talking about additional savings, keeping more folks out of emergency room or higher cost settings, really coordinating that care, something we saw is really important for you all here. If you bring in a managed care company, they're gonna do the same thing. They're gonna have savings beyond this traditional administrative fee-for-service savings. Okay, I just want to make sure that's clear. So as we move on, we now look at the two models. The provider-led care coordination model, or as Dennis Smith referred to this as organized care. I like that name. I want to use that. But these are the providers coming together. We didn't do a lot of review. We didn't have a lot of opportunity or time to really scrutinize, and that's something that Director Gillespie, Dennis, and others are going to be moving forward on, as far as like planning and review, and they'll be able to update the legislature post December. But the current strategy we're looking at, in a nutshell here, is we looked at Colorado, we looked at Oregon, Alabama's a current one. Alabama's been trying to get this off the ground for about 3 years. It hasn't started yet, but it's regional co-ops that are getting together. And we then tried to identify savings. What have been the savings to date in those programs? You know, some are 2%, some are a little over 3%. We're gonna give a 5% savings attached to this model, provided it has the right risk. And it's something that, again, we don't have a lot of information other than to tell you that these models in the past have been somewhere around 2 to 3% savings. I think it's fair to say, with the way that Dennis Smith and Director Gillespie have outlined, that there's going to be more risk here, and it's going to be a little different than what it is, and it's higher cost settings. It's behavioral health and DD. So I think it's appropriate to assign a higher level of savings. Is it 5%? Is it 8%? And I think 5% is what we in our group felt reasonable. So that's kind of what you're going to see here in the next model. So basically what you see is the additional savings due to the provider-led model. What's important is the cost savings plus the premium tax. And I want to underscore that, because they're still looking at legal review on this and whether or not there can even be a premium tax attached. We're supposed to get some information before the final report. Not sure if you will, but that might even be that might need legislation, because I think you're going to need to go into a session and change your laws if you want a premium tax from any provider model. So we're assuming that that's going to happen. We're assuming that if the provider model was in effect, we're giving 3 years for it to actually start to show savings. Now, I talked to Director Steele this morning, and they think possibly it could be even 2 years. Maybe the savings could start earlier. We're trying to be conservative. Yeah, if the timeline happens a lot quicker than some of these other states, sure. But, again, Alabama, 3 years so far, and they haven't even got the model off the ground. And Colorado and Oregon took a few years of planning to get there, and there's a lot of provider discussion here. So it's not something that can just happen overnight. But that's what we have assigned to it. And if you look at that again, notice the 5-year change beginning fiscal 18 now, really, as far as the majority of your savings. Because July of 17 is when you'd start. But if the timeline begins today, they could probably move that up. But this is what we're thinking, close to $1 billion over that 5-year period off of trend. And it gets, off of the halo, it does get you some better coordination of care, which would be really important. Again, we can talk about that, but it's really, then you compare that to capitated managed care. And that's what some of the members asked us to do. We went back over the same numbers that we used for capitated managed care in terms of the savings, and that was the Louisiana model that actually looked at managed care capitated versus managed fee-for-service running at the same time. And the managed care savings were somewhere in the 12% area, and we discounted for net, taking out admin. So net of admin, you're dealing with about an 8% savings in the capitated managed care. We think the capitated managed care, based on its track record, can happen a little quicker in terms of ready to go, because that's already a seasoned market. and we've always said between 18 months and 2 years. And I think here we just basically say starting in 2 years. And you can see where there's going to be it's higher risk and more savings due to track record of prior history. Same premium tax, not a question at all for the capitated managed care plans. And some of the thought in the past, we mentioned the premium tax to be, consider dedicating it to like a wait list. If you do that, you're going to diminish some of the savings, but that is something that you might want to do since it's a substantial amount of dollars if you go down this road. Those are the two models there, Mr. Chairman.
So you're saying that in addition to the 800 million that we are going to do through program reformation, there's another billion if we did it through organized care, or 1.2 billion through capitated managed care?
Another couple $100 million.
Right.
Correct.
Okay.
Correct. There's no question that, in our opinion, there'll be additional savings, whether you do it in the provider model or capitated managed care. And Representative Collins has been pretty consistent on this. There has to be risk involved in the provider model. I know Director Gillespie and Dennis Smith are working on that too. So you'd always want to find out what is that level of risk for the providers going to be. If there's no skin in the game, it's going to be hard to generate the savings. But Dennis, and I've spoken to Dennis, does believe that the incentives will generate substantial savings. I believe in that too, and I think that's accurate. But, how much, that's, again, something that, you'll all have to track. The rest of the slides with regard to this area, and this is all in your packet, is the transition. Slow growth, rapid growth. It's basically what we've been talking about. We looked at some of these other states, how much time it takes for the planning of the provider model. So you'll get a good sense. This isn't something that can happen overnight, but it's clearly something that has happened in other states, and it can happen, but we want you to be mindful not to be too aggressive if you go down this road in terms of booking savings.
Senator Chesterfield, you recognize for a question.
Thank you, Mr. Chair. We just said that the individuals from Beacon should be, if not already are, individuals who are members of the profession that they are overseeing to some extent. Is that correct? But with behavioral health, are there clinicians that are going to be a part of the determination as to prior authorization with that group?
That's the case now, ma'am.
It is
Yes, in fact, their final review is through a psychiatrist.
It's through a psychiatrist?
Yes.
And that would continue to your knowledge?
Under the current contract, yes. Under these different models that John's been discussing, I would hope that those credentialing requirements for these types of administrative services that either the provider-led or the managed care organization would have to have.
This is a better question for the agency, or since the agency's been a part of this provider group conversation?
I think it's a good question for the agency when they get their models mature. I can almost assure you that in a managed care model, CMS will be looking for what the credentialing construction is throughout the administrative services that...
Well, we would hope so.
Yeah, absolutely.
But right now,
It's a work in-
behavioral health, the assessments are being reviewed by psychiatrists.
The final review inside of Beacon, to my knowledge, is by a psychiatrist. If there is an appeal, there is an additional review by a psychiatrist.
Okay.
I believe that their clinical decision-making around medical necessity are by
Easy
licensed
for you to say, huh?
Right, I'm sorry. Are by licensed clinical social workers.
Okay. Well, thank you very much.
Senator Rapert, you're recognized.
Thank you, Mr. Chairman. In relation to this discussion, is there any issues from the Alabama situation that pertain to this?
I mean, I don't know all the ins and outs. I know, Stephen, you looked at the state. I mean, just taking articles, reading research papers, it's been very difficult there to get the regional cooperative model off the ground. And we could dig further, but the most recent article that just came out, I think yesterday, said that they're going forward. Governor wants to go forward, but There's a number of members of the general court that are pushing to stop the regional co-op model, provider model. It just seems like it's a very chaotic situation. Again, I'm just reading, I'm telling you what I'm reading. Do you know anything different?
Alabama was not one of the states that we really focused on in looking at this. Looking at the two big ones that we looked at were Colorado and Oregon, and those both grew pretty slowly over time and now do have most of the enrollees within their care coordination organizations, but they did start slow. So any savings that might be attributable to them started slowly as well.
Just to add to what Stephen is saying, in Colorado, he said it has taken them quite a number of years. That was only on the primary care side. As we speak right now, they finally have an RFP out to integrate their coordinated care provider-led model with behavioral health. They didn't start off with them linked. So it's taken them 4 or 5 years to get to this point where they're looking at an integrated model.
Okay, thank you very much.
I mean, Senator Rayford, it's a good question to ask the agency as they roll out the plans, but, you know, again, it could be a lot less time for this state. And in looking at Alabama, the only reason I'm bringing Alabama up is because when we start looking at how much time it's going to take and we want to be able to book savings for you all in a plan, I'm not comfortable booking savings 2 years out because of what we've seen. That's all. It doesn't mean it's the wrong model, and that's something that you need to dig deeper with the agency, where they're going and what's the best model for your state.
Mr. Chairman, one thing that we might do is let's make sure that we're taking in information about what's happening in Alabama, of course. I think that'd be important to us. It's closer to home as well. So thank you for your time.
And that, you know, that basically concludes this part of it. And then I want to get into the recommendations.
We got one more question here real
Okay.
quick. Senator Elliott, you're recognized.
Thank you, Mr. Chair. I don't know if this is for you guys necessarily or the agency, but for the behavioral health assessments, is there a requirement, do you happen to know, in the RFP that these folks are clinicians, or is it something beneath being a clinician who's going to be doing the assessments? Do we know the answer to that?
Technically, I don't, but I do know that the RFP was designed so that the state would receive maximum broad responses from the vendors by asking them how they would propose to implement the independent assessment process.
Yeah.
So that would include what types of personnel and what kind of credentials that the vendor would respond with.
Mr. Chair, at some point, and I don't know what would be proper, that would probably the agency would have to tell us that, because I think it would go to what the specs are in the RFP, whether or not we're going to have a person who's actually a clinician making that determination, the assessment, or somebody with credentials.
We're going to have Ms. Stone
less than
come
that.
here after the
Okay.
report's finished.
Thank you. In case I'm not here because I have to go to another meeting,
No,
get the
you
answer
need
for
to
me.
stay.
Thank you.
Okay. Senator
that
Chesterfield, you're recognized.
And that RFP, by the way, has been released, so they'll be able to tell you today.
Is Diamond Care dead? Is that what I'm hearing?
I mean, no, we've just been asked to look at these two different models. Diamond Care, it's up to you policymakers. I mean, Diamond Care would be, the difference is, Diamond Care is not that much different than what this provider model would be in the sense that it's a managed fee for service. So.
I just thought maybe I wasn't keeping up, because this seems to, I knew that we were looking at a different model. I knew that we had talked about managed care. I knew that there were meetings going on, so I just needed to know, have we moved past the Diamond Care stage
No.
to the regional provider thing that seems to be the new flavor of the month? I'm just trying to figure it out.
I guess what I would say to that is that this is DHS's chosen path right now. They're moving forward on it with asking for input, and they're supposed to be giving the governor.
We don't have any say in that? You know, God forbid that I overstep my bounds as a legislator, but I thought all that stuff came to us for review. Has the committee already reviewed it?
No, it'll.
Has public health or insurance and commerce or
No,
You know,
let me just, Senator
I'm just
Churchfield.
trying to figure it out.
No, all that
Senator.
stuff, just like the real changes that we've already talked about with DD and behavioral health have had to come through the legislative process. Any of the things that they're talking about with regard to RFPs are going to have to go through the normal legislative process.
Oh, okay, well, help me here, because it was as if we
No,
were
no.
invisible.
No, he's just given, we've had 2 or 3 new models, and he's comparing that with capitated managed
So
care.
we're just in the
versus-
comparison stage.
We are just
Because it
fact
seemed the
finders.
conversation was as if it were already done.
Oh, no.
And I just wondered, I know it hadn't come through here,
No, ma'am.
and I hadn't heard Senator Raper said it'd come through Insurance and Commerce, and I wasn't sure if it had come through Public Health or not, but at some point, there will be legislative review of any proposed changes.
By the Constitution, there absolutely will be. And
We
we'll-
don't always do everything constitutionally.
always.
Oh, yeah, right. Okay. Wink, wink, nod, nod. Thank you. Thank you very
Senator,
much.
I think it's a really good question, so I want to bring your attention to slide 11 again, because this is really important. I want to make sure I got my point across to the committee as we finish up
Slide
the
11's
process.
on what page, John?
So it's a PowerPoint you have.
Okay. This one?
Yep, no, the PowerPoint.
What the hell is a PowerPoint?
It's actually on the screen right now, but you should have it. If not, Phil can.
Gotcha. I got it.
So if you really look at this slide, these are the programmatic changes that are going to happen no matter what the care management model is. So everything you've done in the past year and a half, or more than that, everything you've done is to really drive a lot of this to happen, to hopefully help the program be more
Now,
sustainable.
all this has gone through legislative review.
All this is Rules Committee, and it's all planned in the future, and it's all going through the legislature.
Okay, just
Some of it is actually programmatic changes, like the dental savings, they put an RFP out. I don't know if they need to go through legislature, but most of it's rulemaking in legislature. So some of this may not have exact rule changes, some of it may be just department changes. So for example, if the DHS wants to do more with shared services, if they want to, with internally, they have that right.
They have that right.
But the point here is 893 estimated savings. What we're calculating is rules and other changes you're going to absolutely see, okay? So now, that's really, think of that as task force already deciding to move forward on some issues, because you've asked them to do more on the high-cost populations. Now, when you get into the next slot, the next one, this is on page 13. Now you're talking about a different care coordination model. So what you're doing is taking that 800, you're keeping that same program change, same base, and now you're adding to it an impact of care management, whatever it's going to be. And in this case, if it's going to be the provider model, this is the additional savings. This would all have to go through the legislature as well. But it's going to be well after this task force is done when these decisions are made. And that includes the managed care one, which is on the 15th. Now, we could have given you another one for Diamond Care, but at the end of the day, you or the policymakers are going to have to decide what the care management model is for this state going forward come January. And I'm sure the legislature will take that up.
All right, thank you.
Does that help?
That's helpful.
Okay,
That
Senator.
really is. Thank you so much.
Okay, thank you, Senator.
Senator Ervin, you're recognized.
Thank you. I think it's difficult disconnect because Public Health Committee should have been integrated into this task force to hear and see all that you have presented, because I think there was a disconnect there when rules and regulations and things like this came through Public Health. There wasn't a whole lot of discussion and background for those legislators. So moving forward, hopefully, I think we've learned a lesson from the legislative point of view that, whatever happens, the body that has to review rules and regulations also needs to be the body that sees and hears the presentations before us. So, hopefully that's a lesson learned for our legislature as we move forward. But I do appreciate, the work I think we've just hit some snags because of that lack of communication, unfortunately. But I just want to speak from the public health. I know Senator Bledsoe's not here, but we've had to try to deal with a lot of this in public health with members that have not been as informed, unfortunately, which has caused some difficulty. I just thank you, Mr. Chair, for letting me speak.
Okay. All right, I think that's all on the list, so go ahead.
So I know that Representative Gray is not here, but you wanted to have the department answer some questions on the DD. This would probably be the best time, but if she's not here.
Do you all have other stuff in your presentation?
Well, I would go, at this point, it's the remaining recommendations which are in the packet, in the status report, and I want to be able to go over those.
Okay. I know that Senator Elliott also had some questions for the agency, but why don't we go ahead and ask her to come on down. Ms. Stone, if you'd come on down and kind of give us an update on where we are with these changes. There she is. Okay, if you all would just go down the row there and give us your name, and if you want to just, like I said, give us an update on what you've heard and any additions you'd like to make from what the Stephen Group said, particularly with regard to the progress on some of these measures with the DD waiting list, I'd appreciate it.
Melissa Stone, the Director of the Division of Developmental Disability Services.
Forrest Steele, Assistant Director of Developmental Disability Services.
Gina Davenport, Assistant Director, Home and Community-Based Services.
Dawn Staley, DHS Deputy Director for Health and Medicaid Director.
Dennis Smith, Senior Advisor for Medicaid and Healthcare Reform.
I would like to start by clarifying, just to avoid any further confusion. So on the OT, PT, and speech therapy thresholds.
Yeah, just go ahead and, don't use acronyms.
Okay, on the occupational therapy, speech therapy, and physical therapy thresholds that went through public health last week, that will go before, excuse me, rules and regs in December. We have made commitments to use specialized pediatric clinicians. We do not currently have a vendor in place, and we are not using Beacon. So if we put an RFP out and they bid on it and they're the most qualified bidder, that's one thing, but I did want to clarify that we have no procedure in place at this time.
Okay.
So as for the tiers, so I know that at the last task force meeting, there was some discussion between myself and Representative Gray about the current waiver that we're operating with under, and the one that's out for review at CMS. So we actually had another follow-up phone call with CMS this morning that we feel that we've made some great progress. We had received some informal requests for additional information. As you guys might be aware, Brad Nye is now heading up that unit, and he has been very valuable to DDS since getting involved, and I appreciate him immensely. So he led a phone call this morning where we got a timeline in place for when CMS was going to respond with some additional questions, and they committed to sending them on Friday of this week. Ms. Davenport has committed to working this Friday and answering those questions as the Assistant Director over the waiver. So we've made progress, and we are pushing to have that renewal approved, hopefully by the end of the year. I know that might be optimistic, but I stressed with them again this morning, as well as Mr. Na, the importance of getting that renewal out so that we can go immediately in and make additional amendments for what the legislators asked us to do and what the department is trying to do with independent assessments and tiers.
Okay, Senator Chesterfield, you're recognized.
Thank you, Mr. Chair. Remind me of the tiers.
So we had traveled to Tennessee to look at a tier-based model that they have in place, where they have set pricing for a 3-tiered system.
And so I did remember the 3 correctly. Okay, 3 tiers.
So they have tiers that are in the amounts of $15,000, $30,000, and $60,000. Now, I have been working with Mr. Kellogg on that model because they've had to go in and make some changes already to that model after they've run into a series of problems with those amounts.
What would Tier 1 do? What would be the difference between, besides money, what's the difference between Tier 1, Tier 2, and Tier 3?
So currently, in the DDS waiver that we currently operate, we have a three-tiered system that we refer to as limited care, extensive care, and pervasive care. Limited and extensive care right now in our current waiver have the same daily rate amount. So correct me if I'm wrong, Regina, but I think the daily rate amount for limited and extensive, you can get up to $176 a day. As for pervasive, that you have to show through testing that you require someone to be with you 24 hours a day, 7 days a week.
And this is done, this request is made by the provider.
Yes.
That is then reviewed by an independent assessor.
Not at this time. Now, we're moving forward with the independent assessment aspect of it.
Well, let me get to the heart of my question, because I don't want the chair to become impatient with me. Does the current RFP require that whatever group we have assessing all of this, because the tier thing came back, we've just slept some since that time. Does the current RFP require that the assessors have advanced degrees, or is a bachelor's degree the only thing that's required?
So I can speak for DDS, what we put in the RFP for minimum requirements. So we have requested that at a minimum, the assessors have at least 2 years' experience with developmentally disabled clients, and they meet additional qualifications of what's referred to as a QDDP, which is a qualified developmental disability professional. So that's specific to us. Each division, so DDS, aging, and behavioral health, set minimum qualifications for the assessors for their particular tool.
What does one have to do in order to become a qualified developmental professional?
So I think I have two right here, so I'll let Mr. Forrest, Mr. Steele
Mr. Ford, what is your educational background, sir?
Mine, I have a bachelor's degree in journalism and a licensed administrator.
Of what?
Oh, yes. I've been working with the Human Development Center system since, for 32 years.
But you have a bachelor's degree in journalism?
Yes, ma'am.
And you went on to be, how did you become highly qualified through a bachelor's degree in journalism? I guess I'm at a loss.
Well, to qualify for a QIDP or a QDDP, you must have a degree in a bachelor's degree in a human services field in which you're...
So journalism, so my bachelor's in social studies would just get me there, my master's in social studies would just get me there to...
It possibly might. It depends on the coursework that you undertook as you were getting your degree.
And what coursework did you take that qualified you to be a qualified developmental professional?
Well, the coursework must be related to the human condition, and that covers a wide range of things. My minor is in history, and that covered a lot of courses that dealt with the human condition, psychology. It's a wide range of things.
So as a history and political science major, I would be eligible to become that since I worked with, and having taught school for a period of time. That would automatically qualify me for that?
Not automatically, no. You must have at least 1 year of experience working with a population of people who have intellectual disabilities.
And we felt like 1 year, we wanted something more than 1 year. So we want the qualifications of the QDDP, which is the Human Resource Bachelor's degree plus 2 years experience. So we've upped it to 2 years. Mr. Steele is also a nursing home administrator, and he ran almost all of our human development centers the past 30 years. So he is highly qualified beyond his journalism degree.
Based on the fact that he worked in the field?
Yes, it requires experience in the field.
Help me. These are the individuals who will determine, or an individual of his qualification would get to determine whether or not an individual were allowed to get more treatment.
Senator, if I may, I think there are
Yeah,
two different...
you need to help me with that one,
there are-
because
there
I'm
are-
having a little difficulty with that.
There are two different pathways here. What we have been discussing is the independent assessment of assigning individuals into a tier of services categories. I think your previous line of questioning about prior authorization is completely separate from that.
So he would not be one of the individuals that would be a part of the prior authorization piece.
In our prior authorization, an individual would have greater qualifications, both in the clinical experience as well as experience as well. So again,
I'm
he
just
is
trying to
not
make
prior
sure
auth-
that, see, because it's almost like I stayed at a Holiday Inn last night, so therefore I am qualified. I need to know, and I'm very, very serious about this, because you're talking about kids' lives and adults' lives, and you're talking about having been a victim of prior authorization, and I think sometimes we feel victimized when we have to go through prior authorizations as a result of professionals who have to have these degrees in order to make these recommendations, and we're going somewhere, and you're saying because I was in journalism and I ran some centers, then I need to be able to say no. That's not what you're talking about, surely.
That's not what I'm talking about, ma'am.
Okay.
The
Well,
prior
go ahead and explain it to
authorization
me.
is a separate process dealing with an individual who has a physician who has prescribed a certain level of services, whether they be a therapy service or something else. So individuals who receive that level of services take that physician prescription and get a certain level of occupational therapy services, for example. But if the individual believes they are in need of additional services beyond that, so again, that's what is being prior authorized. We are allowing you this number of units of services. Those are prior authorized. You don't need to do anything else in order to get them. But individuals who believe they need more services than that then would have a right to request more services, and that level of review would be by qualified professionals who then, based on medical necessity, would say, yes, we will prior authorize you an additional 15 units, or an example.
What are the qualifications for those individuals?
Those individuals, again, we will be spelling out in the next step in the process of how we get to prior authorization. But those levels those will be requirements for clinical level of physicians will be in that, psychiatrists will be that, pediatric specialists will be on those types of reviews.
That's
So
giving me less angst, and that will be in the RFP, is that right?
This is a separate process in.
This is
that
not an
will be-
RFP process.
Not in the current one. It will be a separate process, yes, ma'am.
And we can rest assured then that the individuals who will be assessing whether or not to issue the individual the right to have additional care will at least be a physician or clinician, him or herself.
They will have the clinical background that is, they will have the clinical background to be able to say yes to additional services because they're medically necessary for that individual.
Will they be a
or to
medically
say no.
qualified clinician?
Yes, ma'am. They
Okay,
will
because
be
there is a
medically
difference
qualified.
between someone who has run a clinic and a clinician. So I'm just trying to differentiate. We've got one set of standards here for this process that this gentleman is dealing with, but you have another
It's a
set of
sep-
processes
Yes,
for the
yes,
other.
Senator. It's a
Okay,
separate
that-
process, and they will be medically qualified clinicians. Yes,
Thank you
ma'am.
very much. I appreciate it. Thank you for your indulgence, Mr. Chair.
Sure. Representative Gray, you're recognized.
Thank you, Mr. Chair. First, I want to start with independent assessments, as that's what we were talking about. based on kind of what I've read with the RFP, it looks like you're trying to exclude some areas within your control, such as like personal care or DDTCS. Certain things are excluded in the RFP. It's my understanding that Mr. Stephen and the Stephen Group, when they did their calculations for savings estimates, included your entire area for independent assessments. Can you explain to me why you are leaving out some of the areas that should include independent assessments?
So there's a couple of timing things going on, but personal care and DDTCS, as well as children's medical health homes, are state plan services. So they actually had to be pulled out of the Medicaid state plan and put into a different type of waiver. And we're working with the feds on seeing if they could be put in some sort of vehicle such as an I. So we have been working, specifically Ms. Davenport's been working with our federal assistance program that's been helping us with supported employment. Because of course, DDTS, a big piece of that, we're trying to move towards integrated supported employment and get away from people sitting in non-integrated settings. So that is being worked on. What was not in the savings chart that the Stephen Group has put forward, due to a couple of things that's been happening at the department, we are moving forward with putting some parameters in place with DDTCS and CHMS, like a developmental screener, and we are working with DDTCS and CHMS providers to look at the amount of habilitation hours and eligibility criteria. We're just not at the point where we can make those projections, but we do know we'll have anticipated savings on those efforts. I will tell you that when CMS put in some settings requirements, and Mr. Nazian can talk about how this is affecting the entire department, the reason we have been so careful to tread water on not making substantial changes to our current waiver is because if CMS declares that substantial changes have been made, we have to be day one in compliance with settings. We have been working hand in hand with Director Cloud over at Aging on a settings transition plan that we hope to have approved by the end of the year, and if so, we'll be the second state in the nation to have that approved. Once approved, we have until 2019 to get our providers up in compliance. And it is a complete culture shift. And so any substantial change made to a waiver at this point would require day one settings compliance, and our providers are not ready for that.
Okay. If I could, let me follow up real quick. You said that you're looking at doing a new waiver, possibly an I for those populations. So far in our waiver process, it's taken months or years to get these waivers approved. Would it not be to our benefit to add these populations into the RFP for current time until they are placed into a new waiver?
So they are in the RFP that's running right now. DDTCS and CHMS are included in the RFP.
And personal care? Is personal care in there as well, or, I mean, are there?
Ms. Staley might want to talk about personal care for DD clients.
Personal care is a state plan amendment service. So again, one of the issues that to be looked at in dealing with these populations, oftentimes individuals receive services under the state plan and then seek additional services under a waiver.
Mm-hmm. So are they all included in the RFP for independent assessments? Will the independent assessment essentially, well, I guess what I'm looking for and what I think I expect is like the long-term supports and services where they do an independent assessment that covers the whole scope of services. So is that independent assessment going to cover the whole scope of services, and is that reflected in the RFP properly? Okay, thank you. The tiers, you mentioned, Director Stone, at the last meeting that you had submitted these tiers to CMS for approval, and I have asked for a lot of documentation. I have not been able to read through it all yet, but it's not, to my knowledge, what I can find in the current renewal or in even the letter, which I have somewhere that, where is it? The conflict resolution. I'm not finding these tiers anywhere. Could you please let me know where they are?
So I think the discussion that you and I had at the last task force meeting is you were asking if independent assessment was part of the waiver that's being reviewed now by CMS. And I kept, I think we were just miscommunicating when I was saying conflict-free case management, because that's all I've been breathing the past couple of months, because independent assessments are part of conflict-free case management. That is in the renewal that's being reviewed right now by CMS, and that is why I submitted to you guys the concept paper, so you can see what makes up conflict-free case management.
But is that conflict-free case management, it's in this renewal application right here?
Yes.
What section could you?
So it is, and I have an email that gives the section number that was forwarded to you as well.
And then also, at the last task force meeting, you did specifically say, when John Stephen was sitting beside you, when he said that you had not submitted your tiers to CMS for approval, you interrupted him and said, yes, you had, that's incorrect. I cannot find those tiers anywhere, and I would like a description of them. You know, if that's something that you say you've done, that's why I was wanting to compare the two, just to make sure that we are in the process of putting those tiers in place.
No, ma'am, we have not submitted tiers, and I would not have stated that at the last meeting. I was talking about conflict-free case management. Mr. Stevens and I have been working on a timeline, and I committed to a concept paper that Ms. Davenport and I are writing that will be turned in December.
Okay, so the tiers are not done yet. When do you expect the tiers to be ready and to be, are you going to put them in the renewal, or do we plan to get this renewal approved and then try and amend later?
So CMS, based on phone calls we've had and a follow-up again this morning, will not let me put the language in the renewal. They are asking that it be renewed, and then we immediately go in and do an amendment. And Mr. Nye can talk about that at length. He's been working on our behalf.
Okay. Was the long-term supports and services, so like when they did their renewal this year, they made some fairly substantive changes to that as well? She's shaking her head no, that they did not make those changes. I just wondered why one area is being allowed to make changes and another area is not.
Do you want to talk about that, Ms. Davenport?
I would. Long-term care or aging, what they did was they combined two waivers. So those other waivers basically went away. So that's what the difference is between what they did and what we are doing. What we are doing, we're not eliminating the waiver, we're renewing it as is, and then doing the amendments that are needed to bring it further into compliance. And that's two separate processes. When they actually combined their waivers, the other two old waivers went away. They had to actually transition those individuals into this new waiver that they have, which is called AR Choices. So that's the difference.
Okay, so then I'm going to assume that we get this approved, you're going to do the amendment. So are you currently wanting to leave everyone that's on this where they are, and then all new beneficiaries go into the new model? Because I think it was my understanding that we did want everyone that's currently on this waiver to be reevaluated like within the first 365 days to see where they do fall within the tier.
I agree with you. So we will, day one, starting July 1st of 17, we will start assessing the entire population. So anyone currently on the home and community-based waiver, it's about 4,200 people, any new people coming in, anyone going into a private ICF, anyone going into a human development center. The difference is, because we have been operating this waiver for such a long time under this kind of setup, and people have been able in the past to do one-bedroom apartments with one-on-one staff, and we have got to get away from that and get into a shared staffing model. We are proposing and asking CMS to allow the current recipients to receive one assessment so that providers can start planning, and then they will actually be forced to go into the tier starting July 1 of 2018. So I think on the Stephen group, they put 2019. It's not, we'll receive savings in fiscal year 19. We're going to start the process on July 1 of 2018. Now, any new people that have never been on the waiver, they'll immediately go into a tier July 1 of 17.
Okay, so within 1 year, we will have everyone that's on this waiver assessed and put into the tiered system. There'll be no one left on this old system.
Yes.
Okay, that's great. Just one kind of final question here. when do you foresee CMS approving this? And then when do you plan to file your amendment? And when do you foresee CMS approving that amendment?
So Ms. Davenport and Mr. Nye and I were all on the call this morning, and Ms. Davenport and I tried to put some pressure on them to get this approved. So we made them commit to us that they would have this approved as quickly as possible, because technically they have 90 additional days from today. And we tried to instill in them that that was not going to work. Ms. Davenport told them that she had been drafting all of the amendments and would like to send them to them after Thanksgiving. So we're trying hard not to confuse them. We want the renewal approved so that we can start doing the amendments, but we also want to put enough pressure on them where they see the substantial changes we're trying to make.
Okay. Would it be possible, like if you have the tiers and you have all that determined already, even though you haven't sent that to CMS, could you send that out to the task force so we could look at what your tiers look like?
The way is not finished. We are drafting that concept paper. We've been working together to get it out, and our goal was to have it ready and sent to CMS the 1st of December.
Okay. Once it's finished, could you please send it out to us? And then I'd like to see the tiers, and I'd also like an explanation in that of how the independent assessments will essentially funnel people into the tiers.
Okay.
If that makes sense. I think that's all I have right now, Mr. Chair. Thank you for allowing me leeway.
Sure, appreciate the good questions. What we're going to do, we've got one more on the list for questions, and then we're going to take a lunch break and come back. We've got item F that we skipped. We're going to come back and pick it up, and then I think the Stephen Group has a little bit more. And one of the things that I'll be asking both the Stephen Group and our Mr. I think it's a hard name to say, so I may not try, Condalucci to talk about is perhaps what potential changes based on the administration change might be we'll be looking at in the upcoming months. So that's our plan. We have one more. Senator Ervin, you're recognized, and then we'll take a lunch break.
Thank you. It's just a simple, quick question. In 2015, I passed the Prior Authorization Transparency Act. I'm just wondering if that's something that's going to be, if that law that we passed will be factoring into, I realize you're writing a contract on prior authorization, but will that law that we passed in 2015 be taken into consideration, or do you foresee changes that are necessary? I'm just trying to get a feel as to how the laws that we passed on prior authorization will affect your contracts.
Absolutely, both the Prior Authorization Transparency Act you referenced, as well as Medicaid fairness and other things. Okay. Those are all factors that will be taken in consideration as we write these RFPs.
Well, I think, for members that have some anxiety about the prior authorization, which I completely understand, I think we thoroughly addressed it in this act in 2015. So just for members to alleviate maybe some anxiety there. Thank you.
Okay, members, we're going to go ahead and take a lunch break. We're going to come back. It's going to, but before you leave, I'm going to ask Representative Hammer, this next guest is here at his request, so if you want to tell us a little bit about him.
Thank you, Mr. Chair. Chris is here, and one thing we need to know is that he served he served as Tax and Benefits Counsel to the U.S. Senate Finance Committee whenever the ACA was being drafted. As far as being in the trenches from the beginning of the ACA development, he was one that was in the room in all the discussion as chief counsel. He also will bring some knowledge as far as what states can do with regards to exchanges and the insurance market reforms that the tax enacted under the law. So he brings a wealth of knowledge that I think is going to lend to what the Stevens Group has been talking about a little bit, as one that was there when it was all being developed. And he said it's come in here on his own dime, just flew in from Washington to be flying back all at his expense. So appreciate the courtesy of the members to be here to hear what he has to say and benefit from his knowledge. Thank you.
Okay, and because he has an afternoon flight, we're going to start promptly at 1:15. So we're being here in your seats a few minutes after 1, because at 1:15 we're going to start, and we'll start right with Chris. We'll take a recess